Good afternoon, everyone. My name is Sherwin Morgan, and I'm from the University of Chicago Medical Center. And I'm actually in practice, do clinical practice and development for the Department of Respiratory Therapy, which is a section of pulmonary and critical care medicine. I have no real or perceived conflicts of interest as it relates to this presentation. So any brand names is not meant in any way to be an endorsement of any specific product, but merely to illustrate a point of emphasis. So respiratory syndromes caused by viral infections have been a major global concern for the healthcare community for centuries. It significantly affects morbidity and mortality with regards to children with and without premorbid conditions when associated with viral bronchoconstriction related respiratory failure. It has a huge impact on global healthcare resources and finances. The etiology of these infections is that, pardon me? Oh, full screen. Where at?
Oh, you already have that? Okay.
Enlarge.
How did you get it? Is it like from the file itself? Or?
Probably.
Okay. Like, did you get it from the, I'm sorry, is the file right there?
Yeah.
Where's the tool in there? Okay.
No, thanks.
Sorry about that.
Sure. All right. I've been through that. So 30 years of clinical practice and observations, and so lessons learned. So we're going to classify classification of airflow obstructions, how to clinically identify respiratory syndromes, and then respiratory care interventions when dealing with these type of things. So there are basically two types of airflow obstructions that we're noticing. So airflow obstruction 1 is from asthma, and airflow obstruction 2 is from viral bronchiolitis, which is actually more deadly than asthma. So global influenzas and vaccine prevention. Most of the vaccines that are produced today are of the HN nature. And so there are not a lot of vaccines outside of the HN influenza structure. These vaccines are less effective against premorbid conditions and are more acute in situations that are exacerbated by cold and flu, and which cause respiratory distress. And so what we see is we see asthma, immune compromised, small children, malnourished, pregnancies. These can cause acute respiratory distress. And in the past 6 weeks, Chicago has experienced a great increase in the amount of animal and human related flu admissions to the veterinarians and to the hospitals. It's the same illness whether you are young or old. You either get the common cold or severe acute respiratory distress-like symptoms. Increasingly, these respiratory syndromes, such as rhinovirus, enterovirus, are recognized as precipitants of acute respiratory distress and respiratory failure. And so these syndromes mandate hospitalization. And as I do clinical practice in both the adult and pediatric arena, respiratory syndromes are grossly overlooked and underestimated as the root cause of respiratory failure and the reason that the patients are in the ICU and on life support. It is important to accurately understand and identify the source of respiratory distress, as it often masquerades as asthma-like. And so viral wheezing or bronchospasm is not the simple asthma like bronchospasm, but it's actually related to bronchi-related bronchoconstriction. And because the initial differential diagnosis includes asthma, it often leads to treatment confusion, too much emphasis paid on the asthma component of the airflow obstruction, And as of today, the American Academy of Pediatrics do not recommend the use of bronchodilators, and this is controversial. So first-line bronchodilator medications are not usually effective for the relief of the respiratory distress. So the influenza, the etiology of the viral-related airflow obstruction is that it affects the airway wall. It causes either swelling, constriction, or thickening. The airway wall changes are not clearly defined, but the hypothesis is that millions of viral cells are attacking the airway wall, causing medication not to be absorbed, like albuterol or the inflammatory agents. And then those changes causes what we call the peribronchial wall thickening. And we're actually, I have more questions than answers now, because as I go back and look at these patients' x-rays, they all show that they have some type of airway wall structure. And so is this temporary or permanent? And so we're now seeing that this is caused by multiple viral agents, and we're starting to see more and more patients with co-infections. And we actually had one patient who was back in PGICU 3 times for viral-related respiratory failure. He had coronavirus and rhinovirus enterovirus. Each time on his x-rays, it indicated that he had a peribronchial airway wall structure thickening on, and he had to be mechanically ventilated with Heliox each time. So the question is, how many in the audience know what Heliox is? Okay, so it's a mixture of helium and oxygen. We use 80% helium, 20% oxygen. So this is just a little diagram that shows what the normal bronchial look like. And over here, it shows peribronchial thickening of the smooth muscle, which appears to be enough to cause enough airflow obstruction in a human lung to cause hypercarbic respiratory failure. So this is a list of all the known viruses that can cause respiratory syndromes that affect both animals and humans. And so these viruses are linked to pulmonary exacerbations which cause bronchiolitis and or pneumonia in various combinations. And they can be transmitted between both humans and adults. So caution, do not underestimate these viruses. They can be deadly. One of the viruses that we're really afraid of right now is the Middle Eastern SARS. And so who knows what is the originating virus for Middle Eastern SARS? Is it RSV, or is it rhinovirus, or the adrenovirus, or the coronavirus? All right. It's actually out of the coronavirus family. And so, if someone's been traveling to the Middle East, they come into your institution with respiratory distress, you isolate them, and then you want to ask them, where they've been. And if you get a RVP, which is a respiratory viral panel, that is positive for some type of coronavirus, it's a pretty good idea that this patient might have the Middle Eastern, not SARS yet, because when you go to SARS, you have infiltrates and you have some type of organ failure. So you're in the pre-phase, what we call it is SARS-like. And we're seeing a lot of patients on in the immune-compromised area that have the peri-influenzas. So we use clinical asthma scoring to assess these patients in the emergency room. These assessment systems include respiratory rate, pulse oximetry, dyspnea, respiratory retractions, auscultations. The results give the staff an indication of when to escalate care. And so I was stationed in the ER back in 2014 where we received over 600 kids who had the rhinovirus, enterovirus infections. And so our main assessment was the clinical asthma scoring. But actually what we found is that high flow nasal cannulas of high humidity actually work tremendously with these patients. Chest x-rays, we see that they have bronchiolitis, or that they have peribronchial thickening of the airways, or even in one case, we were able, the radiologist was able to see retrocardiac atelectasis due to mucus plugging in the airways, hyperreactive airways, and pneumonia. So this is the dynamics of airflow obstruction related to complex respiratory failure. So asthma is smooth muscle related, lower airways, and so you get air trapping in the lungs with hyperinflation, and that equals hyperoxygenation with impaired ventilation. So with this, you can't get the air out, you're getting more in. This may impede venous return, which may dampen your blood pressure. Airflow obstruction 2 is actually from bronchoconstriction, and this impedes alveolar gas exchange at the bronchial interstitial level, and so it causes hypercarbic, hypoxia, which leads to pulmonary hypertension. And so if this is not readily recognized in the clinical arena, what you'll get is ventilation plus nitric oxide, proning, and either isoflurane, and then these patients go to ECMO, not good. So early detection and recognition of the severity is critical for survival if detected before comorbidities set in, such as ARDS, kidney failure, and other organ failures. So if you're at an institution that don't provide all these other modalities, it's better to move the patient earlier rather than later for rescue therapies to be effective. The mortality rate for ECMO is 38%, and it has more complications associated. The use of Heliox in this case is not well studied for hypercarbic respiratory failure of unknown origin, but it should be used earlier. Once the patient gets on the other side of that bell curve, where there's infiltrates on the x-ray, which equals ARDS, kidney failure, the prognosis is poor, and so your ship is important and ready to sail. Heliox has been used for more than a century to treat obstructive pulmonary disease, and it's a specialty gas of 80% helium, 20% oxygen. And so the lower density and high viscosity of Heliox mixtures relative to nitrogen-oxygen mixtures can significantly reduce airway resistance. And so this is a slide from the American Lung Association, and so it actually shows this is a healthy bronchus with nothing there. This is an inflamed bronchus that has excessive mucus in there. And so this is the source of airflow obstruction, where you can't get no air in nor out, and medication in nor out for alveolar gas exchange to occur. If it was asthma, it would probably be in the lower airways, and you see hyperinflation down here in the alveoli. So clinically, Heliox indications is associated with asthma, COPD, and we actually used it for upper airway obstructions from croup, post-extubation stridor, and subglottic edema. There are studies out now that show that Heliox may enhance bronchodilating effect of beta agonist drugs. As of now, there are several products being produced commercially to interface today with respiratory care equipment for like mechanical ventilators and Heliox. So I will present three patients who had influenza-like respiratory syndromes with respiratory failure, who were treated with Heliox, who had resolution of their respiratory failure through the use of Heliox. All three patients had rhinovirus, enterovirus, and one patient had three of the virus. He had coronavirus OC43 on top of it. So the first case review is a 10-month-old male with a history of seizures who was intubated in the field during a seizure episode and it was transported to the University of Chicago Children's Hospital. He was admitted to pediatric ICU for ventilator management and started on seizure medications. Upon admission, his chest x-ray showed that he had left lower lobe aplasia consistent with atelectasis or pneumonia. His RVP was positive for rhinovirus enterovirus, which was verified by PMR, and he was put into airborne droplet and contact precautions. Over the next 2 days, the seizures were controlled, and he was extubated to high-flow nasal cannula at 100% in 5 liters per minute. But once he got extubated, he started immediately breathing at 50 breaths per minute. So he was on Q2-hour beta agonist and CPT therapy. He had no wheezing or stridor, but he had coarse diminished breath sounds. He had intermittent fevers. He had suprasternal chest retraction graded as +5 using the Pediatric Advanced Life Support Scale. He was agitated, fighting the mass treatment when we were doing it. And so I actually picked up his care 48 hours after post-extubation. So we switched him to a new, different type of aerosolized medication delivery system. So this is we actually deliver his inhaled medications through a high-flow nasal cannula. So if you look here, this is a vibrating mesh nebulizer. This is where the gas flow comes in and goes through here. The medication is put in the chamber here and off to the patient. And you can see it. You lose less medication that way, and it's actually a better delivery system for delivering aerosolized medication to small children. And we actually have started using this to deliver continuous albuterol medication. And we're changing the terminology from continuous albuterol nebulizer therapy to volumetric delivery, because we actually use undiluted albuterol and we run it through a syringe pump. And there's a slide letter that describes that. So despite the intense therapy, he was still breathing at 60 to 70 breaths per minute, 24 hours post-extubation. He was desatting into the 80s. He speed up, slow down. And so we were thinking, well, is he having a central or peripheral chemoreceptor response here? So we continued the inhaled beta agonist, and we gave him intravenous methylprednisolone. But the ICU team became very concerned that he was depleting his respiratory muscle reserve due to his increased work of breathing. Like I said, when I first walked up on the kid, I thought that he was having post-extubation stridor, and so I really couldn't put my finger on what the problem actually was. And he was desatting even though he was on 100%. So we considered more aggressive respiratory options like bilevel ventilation, infant nasal CPAP, or even reintubating the kid. But because patients with airflow obstruction can be very complex to manage on positive pressure ventilation, the attending and I actually decided to give them a try of high-flow nasal cannula and Heliox together to prevent intubate or reintubation. And so pre-treatment, he was breathing at 70 breaths per minute, chest wall retraction, nasal flaring, and suprasternal chest retractions. And so this is how we actually ran the Heliox through the high-flow nasal cannula. It's an antiquated system here, but so this is your tank of Heliox on the side. It's an 80-20 mix. We have Heliox compatible flow meters here, and you run it through there, and then you mix in air and oxygen, and then you analyze down here to see what the final mixture is going to the patient. We've since upgraded our treatment protocols. There are now Heliox blenders out. And so these blenders, they are not calibrated for Heliox, so you actually have a flow conversion chart here. You set your FiO2, so this will be 70% helium, 30% oxygen, 60% helium, 40% oxygen, and the 80-20 mix. The reason we don't use 100% helium is because it can, at 100%, it's an anoxic gas. So this is why we use the 80-20 mix. Before that, he was on 5 liters. His SpO2 was 93%. He would intermittently drop down to 84%. And so we had to figure out how much flow to give the kid with high flow. And so with that, there's 2 rules of thumb. You can either set the flow rates at 2 liters per kilo of the patient body weight. But in this situation, the other rule of thumb is you can use minute volume. So you and I, standing here right now, my tidal volume is about 500. And if I'm breathing at 20 breaths per minute, so 500 times 20 is 10. And you want the gas flow to be at least 4 times that, so we would start out at 40 liters per minute. And this child, we estimated his tidal volume to be at about 35 cc's. He was breathing at 70 breaths per minute, so 35 times 70 gave us an expired minute volume of about 2.4, so 2.4 times 4 started out at least 8 to 9 liters per minute. So he started out at 70-30, and then eventually moved to 60-40. 1 minute after going on the Heliox, his respiratory rate fell to 36 breaths per minute. The chest retractions improved, and he appeared to be working not as hard to breathe. So during the first 24 hours, I was still trying to figure out what was going on, and the nurse looked at me and said, Sherman, what's coronavirus? Because I didn't know at the time. That's how, severe with a lime in it, I guess. But we took it serious, went to the World Health Organization, and we figured out what it was. But anyway, during that first 24 hours, all of a sudden his monitor went from 38 to 40, 50, 60 breaths per minute. He desatted. So I poked my head into the room and looked, and the Heliox line had become disconnected from the circuit, and just that quick, he went back to its previous state. Line was cleaned off, put back on. Within 20 seconds, his respiratory rate went from 60 down to 27, and his SpO2 improved. So after that, his condition improved from critical to stable, and we also added aerosolized Pulmicort to his treatment regimen, and along with racemic epi, we thought that might work. So there was no deterioration when we gave the medication through the high-flow nasal cannula circuit. But with improvement of his respiratory status, the albuterol treatments were changed to Q4 as needed. We gave him nutritional support, and CPT was continued. Heliox was discontinued on day 3. He remained on 7 liters of oxygen. He was discharged from Peds ICU on day 10. On day 7, or after 10 days in ICU, 7 days later he was discharged home with clinic appointments. So, ventilator strategies. This is very interesting. So when we have somebody on ventilator with Heliox, we use the low tidal volume strategy. So we use 4 to 5 cc's per kilo. We want to control the patient's breathing. So they will be doing deep sedation and paralytics. Plateau pressures. We want to monitor plateau pressures. If your plateau pressure is greater than 30, then you want to decrease the tidal volume until you get to a plateau of less than 30. And this is so that we can avoid ventilator-associated lung injury. Look for auto-PEEP. With auto-PEEP, it's usually set the set peak is higher than the measured peak. And so this is an interesting slide here that we produced at the University of Chicago back in the 1990s. These were asthmatics who were mechanically ventilated, continuous nibs, on steroids, and get continuous nebulization through the ventilator. And so this is our historical group. So the p-values are not of statistical significance. And we looked at AA gradients in these patients. And so the AA gradients did not change appreciably in this group of patients. They were 226 toward the start, and after 90 minutes only down to 181. FiO2 is still at 80%, and FiO2 was still 60%. In the Heliox group, this was a much sicker group of patients. If you look at patient number 6, pH of 6.79, a PCO2 of 197. And so he's sedated, ventilated, paralyzed, continuous nibs, and he is not thriving. So we added helium, and within 90 minutes, his PCO2 went from 197 down to 102. And within 4 hours, he had normal gases. Patients number 9 and 10 that was a 3-year-old, and that was a 2-year-old that came to our unit from outside hospitals who had, acute hypercarbic respiratory failure. And so within 90 minutes, their PCO2 had gone down to at least a permissive hypercapnia stage in that case. But this is the most interesting slide. In the group, all those group of patients, we looked at the AA gradient, and it looks at how the gradient, how the Heliox affected gradient in 90 minutes. So the AA gradient was 216 toward the start in these patients. And what we did was we changed the FiO2 from an average of 100 to 80% down to either 40 or 30%. And the AA gradients actually came down to 85 after 90 minutes, which was of statistical significance. And the FiO2 was 0.002, which is of statistical significance. Okay. So this is how we actually run Heliox through a mechanical ventilator. There are machines out there now which has the software built into them. This is a servo McKay vent. And as you can see, there's your Heliox tank there, which is 80/20. And then there's a hose that goes to here on the ventilator. So what will happen is, normally there's a yellow compressed air line that fits into the air wall of the hospital side at 21%. What you do is you pop that off, pop that on, and so once you pop it on, the ventilator will automatically know that you're on Heliox, and it'll say the system compensated, alarms adjusted, check your settings, okay, and now you're running on Heliox. Okay, we also changed the way we deliver medication to these patients. So everyone is used to doing continuous albuterol nebulizer where you mix it with regular albuterol and then with saline. But because we're using this nebulizer, it's called a vibrating mesh nebulizer, which fits right here in the circuit, we can actually do undiluted albuterol and run it through here, and it has software for that, and every so often it'll nebulize. So if you look, all our syringe pumps are now programmed with the albuterol in the library. And so if you're going to do 5 milligrams per hour, it'll give you 1 milliliter per hour, but we have it programmed for 20 milliliters per hour, so it's actually going to deliver 4 milliliters of albuterol undiluted for that hour. So case study number 2 is a white female, 16 kilos. She was transferred to Comer Children's Hospital from outside hospital for hypercarbic respiratory failure. At the Outside Hospital, she had a PCO2 of 118. She had no previous history of asthma. She was intubated at the Outside Hospital, and she could not be ventilated on the transport ventilator, so she had to be hand ventilated by air transport. Her x-rays showed when she got there that she had peribronchial thickening of the airways, which was moderate, and she was positive for rhinovirus enterovirus infection. This is her medication list. 24 hours before, so she's getting the kitchen sink and then some thrown at her. So she's got continuous albuterol, 15 milliliters. She's on aminophylline. She's getting cysts. She's getting fentanyl, cimetamines, midazolam, terbutaline. And so after that, with all that, she still only has a pH of 6.99 with a PCO2 of 107. So we switched her over to the helium, and within 3 hours, her pH went up to 7.11. Her CO2 dropped to 77. By day 2, she had semi-normal gases. I'm assuming that she was having some type of asthma event, but when I looked at the plateau pressures on her ventilator, they were only 22. So if this was asthma, I would expect to see high plateau pressures and high peak airway pressures, and I did not observe a lot of intrinsic peak. So this was viral-related respiratory failure. But she stayed on the vent for 8 days, but her course was complicated by severe post-sedation delirium. And so even after a year, she was having some episodes there. Case study number 3 is actually an adult patient. And so this is a 36-year-old male with a history of asthma who was transferred to us for management of hypercarbic respiratory failure. Initial management was he was at home for 3 days, couldn't breathe, and so he's taking his NAB treatments continuously. And so he runs out of medicine, goes to the emergency room. And so he gets 3 days of mass ventilation and 72 hours of albuterol continuously. His CO2 goes up to 115, so he gets intubated and requires mechanical ventilation. So he was deeply sedated with propofol and fentanyl, and he was paralyzed. And so they were still thinking that it was bronchospastic related, so they actually gave him isoflurane through the anesthesia machine at the referring hospital in the hopes of relieving the bronchospasm and improving the alveolar ventilation. So when he gets to us, he has a CO2 of 111. So we were thinking that it was still asthma, so we put him on a Heliox compatible ventilator. But this is when the x-ray came back after he got to us, it indicated that he had retrocardiac atelectasis, which was likely due to mucus plugging in the airway. And when you look at his RVP, it showed that he had rhinovirus enterovirus infection. And so this is pretty much what the airways look like when you get that mucus plugging and airflow obstruction from that. And what we were talking about yesterday in the meconium aspirations, this is what I was thinking, when we gave, if we can do, the guys in Poland use helium to treat meconium aspiration, and it showed it would be some benefit. And this would be an indication of, getting airflow and improving alveolar ventilation through airways that are obstructed. So when he got to us, his pH was 7.11, PCO2 was 71 after 3 hours. After day 2, he got an SPT trial and was extubated. So originally he was coming to us for consideration for ECMO for asthma. And his case was complicated also by significant muscle weakness due to prolonged neuromuscular blocking agents. So discussion, respiratory syndromes are frequent causes for asthma, status asthma-like exacerbations that are very difficult to manage, even with today's modern-day medicine. Viral-related bronchoconstriction appears to be the etiology of these exacerbations, although there's little data to exist regarding the efficiency of Heliox for the treatment of viral-related pulmonary exacerbations. But Heliox was first reported to be used in 1935 by Dr. Bard. He observed that breathing Heliox appeared to relieve dyspnea in children and adults with asthma and upper airway obstruction. In 1950, Dr. Peabody, Levine, and Bard, they called it generalized obstruction of the airway or partial obstruction of the airway that gave the general appearance of asphyxiation accompanied by rapid shallow breathing. And they said total obstruction of the airway is not compatible with the living. Although the early reports were non-controlled, the improvements observed in these patients strongly suggest the positive effects of breathing Heliox. And as was witnessed in our case, relapse occurred when Heliox was discontinued even briefly. Regardless of the possible contributions, our patients appear to respond to the helium concentrations. And so the morbidity and mortality is significant with regard to infants and children. So I kind of liken this to viral respiratory airflow obstruction. I fly in an airplane with turbulent airflow. And so you have to trust your clinical instrument or clinical information when dealing with these patients, because you only have so much time before it gets into the ARDS, organ failure stage, and then you're on the wrong side of the bell curve. So application of Heliox is not widely recognized and considered an adjunct in this situation. So between the years 2012, 2014, we've seen over 1,200 kids were admitted for one or more of the viruses. Some patients had comorbidities. 2014 summer, we admitted over 600 kids. 12 were near fatal. And two of the cases where they didn't recognize the respiratory failure, the kids wound up going on ECMO, and then one was fatal. Many of the kids were treated with different combinations of Heliox, which was through bilevel ventilation, high-flow nasal cannula, or mechanical ventilation, but the majority of the diagnoses were rhinovirus, enterovirus. So there have been few prospective studies on the use of Heliox for respiratory syndromes. The studies that are out there are from RSV, and so Marina Torres and his group looked at 38 non-intubated kids with RSV using the clinical asthma scoring system. They found significant improvement in scoring with Heliox after 1 hour treatment when compared with the control group. And the total average decrease in scoring was 4.2 in the Heliox versus 2.5 in the control group. Kemeny et al., they looked at it at 69 kids with viral-related bronchospasm, and there's a mean change from baseline of 1.84 versus 0.31. And so the only prospective study for bronchiolitis is by Hallerman et al., and I have a reference slide at the end of the presentation that you can look at. So the benefits of effect of breathing Heliox is derived from reduction in airflow obstruction, changing the airflow to a more laminar airflow into the airways, and this airflow helps with mucus plugging. In the normal hemorrhage, the resistance between varies with the density of inspired gases. And so in the 10th through 20th generations, the density of is independent because of airflow in this region is laminar. But because the pressure decrease occurs in the more proximal airways, it can decrease the resistance by 28 to 49% in these patients, even in normal subjects. So with you and I, our normal resistance is 3, but in these other situations, it can go up as high as 40% or more. And so this is why we think that Heliox might work in this situation. So the airway resistance can increase by 50%, of much of it related to obstructive airways, and mucus plugging and structural changes. And this is why we think Heliox might work, because it helps with airflow through those regions. Often overlooked, it appears that bronchoconstriction might be the etiology behind the respiratory failure and may be the main source of airflow obstruction and medication entry into the lungs. And because Heliox reduces non-elemental airflow, it might lead to improved airflow obstruction in these situations. Conclusion: more than a century has passed, and there's inadequate studies to definitively determine the role of Heliox in this situation, which has now shown the ability to affect large populations of both animals and humans. To our knowledge, this is the first report of Heliox being used as an adjunct therapy to treat viral-related influenza-like respiratory failure with resolve. The hypothesis was that the combination of treatments might have a cumulative effect for the attenuation of acute airflow obstruction. Clinically, these patients' breathing improved with Heliox. All three patients, general, continued to improve after 48 hours of Heliox, the use of aerosolized corticosteroids and nutritional support. So the Heliox appeared to serve as a bridge support to these patients while time and pharmacologic measures took an effect and an underlying infection abated. Because these patients' response may vary, a trial of Heliox should be considered when caregivers are confronted with patients with airflow obstruction who still have respiratory reserve and are refractory to current treatment modalities. Of course, these patients should be monitored closely for acute changes, and more prospective studies are needed to understand, recognize, and treat viral-related airflow obstruction and the role of Heliox in the treatment of viral pulmonary exacerbations, which are now documented to be caused by an increasing number of viral agents. All right, complete. Any questions?